Ethical Perspectives on the News is produced by the Interreligious Council of Linn County, which is solely responsible for its content. The views and opinions expressed on this program do not necessarily reflect those of the staff and management of KCRG TV9.
Welcome. I'm Bob Rush, your moderator for today's discussion. We're going to be talking about organ transplants. And just by way of background, some 6 people will have been added to the waiting list for transplants by the time this program has been completed. Some 80 or more people have had transplanted organs today around the country. And unfortunately, nearly 24 will have died because the organ they needed was not there. And so today we'll talk about what the process is, how did we get here, where do we go from here? Our guests are distinguished. Dr. Alan Reed is a professor and chief of transplant surgery, University of Iowa Hospitals and Clinics. Also, he's the director of the University of Iowa Transplant Center. Dr. Christie Thomas, University Hospitals, professor of internal medicine, a kidney specialist, among other areas. And Suzanne Conrad joins us. She is the CEO of the Iowa Donors Network, and she's going to tell us more about that as the program moves on. So Dr. Reed, historians have told us that there was some experimental transplants to perhaps centuries ago. But would you kind of bring us into the modern era? Where are we as far as transplants today?
Sure, Bob, and thanks for having us. Well, I did a little reading in preparation for this, and it turns out the first transplant was actually a corneal transplant, and that was done in 1905. I thought you'd be interested in knowing that. But the first organ transplants were really done in the 1950s. Those were kidney transplants. And in the 1960s, we transplanted pancreases, and the first liver and heart transplant was done in 1967. And we've come a really long way to the past couple of years, where, as your audience might know, within the last year, we've started experimenting with what's called xenotransplant, or transplants across species, where we've actually transplanted experimentally organs, genetically altered organs from pigs into humans. And over the years, there have been a number of things that have improved to allow us to do this. We have better drugs to lower the human immune system. We have better ways to preserve organs. We have a better understanding of the immune system and drugs to control it, to prevent rejection. We have better ICU care, better surgical operative techniques, better way to preserve organs. And so all of those things have really gotten us to where we are today, where the results are really quite good and patients really expect a good outcome, leading to a better quality of life.
Thank you. Anything to add, Suzanne or Dr. Thomas?
I guess I would just say that thanks to the generosity of people, particularly here in Iowa, we have done a good job of being able to recover organs and get those organs transplanted, whether they stay here in the state of Iowa or whether we facilitate a transplant for someone across the country. Thanks to technology and communication and air travel, we are able to move organs and people and get a lot of people transplanted. Last year, we broke all records, and 41,000 people in the United States received an organ transplant. So that's even despite COVID. So I think things are good, and they probably are going to continue to get better.
How does the United States stack up with other countries across the globe as far as transplants, waiting lists, donor lists. Back to Dr. Reed, anything to?
Yeah, well, I think we do remarkably well, Bob, but we could do better. I think there are reasons that we've done well over the years, but there's always room for improvement. So in terms of number, and this is measured by number of organ donors per million population, we're actually doing quite well. We're second to Spain among the countries in which this is measured. Um, Spain has about 50 per million donors per population, and we're about 36, 37 per million. But many countries outside the United States use different techniques than we do. So, for instance, in this country, we have an opt-in for deceased donors, where organ procurement organizations like Iowa Donor Network have to approach families and ask them to be donors. Countries like Spain, Singapore, Austria, Wales, Scotland, and England have what's called an opt-out mechanism, where people are presumed to be donors unless they opt out. And 10 out of the top 14 countries in organs per or donors per million population actually have an opt-out type policy. Other countries also have more aggressive approaches to other types of donors. They tend to use donors more locally than regionally. Some countries use a reward system. So, for instance, Israel, if someone in your family has donated, they will benefit a patient who's on the list in that family. And not being judgmental, but other countries use a market-based system. So Iran, regardless of what you think about the politics or what goes on there, has a somewhat limited market-based system, and they've essentially wiped out their waiting list. So there are ways, some controversial, some less controversial, where we could do better.
Dr. Thomas, I've read that there is a black market for some organs in a few of the countries. I've read $150,000 for a kidney. Cornea is only $25,000. Is that much of a problem internationally?
I believe it is, Bob. And part of the problem is that we have an enormous demand for a variety of organs, and there are many people on the wait list that die waiting. Deceased donation, which forms the bulk of organ transplants in the United States, is not as well advanced in many other parts of the world. And for practical purposes, in some countries, the only source of organs is living donors. And because there are not enough people with healthy relatives that can donate, a black market can appear. In other countries, there are no regulations that prevent the trading of organs or prevent a black market. And so in any situation where there is a scarcity and there is the potential for an unregulated system, a market for organs can appear. In some countries, this is a regulated market. In other countries, it is completely unregulated. As a consequence, in countries with limited resources, it is the poor and the vulnerable that tend to be exploited, and in some cases will sell their organ to make a living, and in some cases are forced to do it by unscrupulous people. Unfortunately, this is a consequence of countries that don't have enough to provide for the needs of their people.
In the United States, the billionaire doesn't go to the front of the line for an organ. Would you talk about how the American system of distribution works? Who wants to lead?
Well, I guess I can start by saying that since 1984, when a federal law was passed, it created something at the federal level where we recognized that organs are a scarce national resource. And because they are viewed as a national resource, the federal government created something called the Organ Procurement and Transplantation Network. Now, that's a mouthful, and so it's usually just abbreviated as OPTN. But the OPTN is a group of people that create policies for organ sharing. And I've spent several years on the board of the OPTN. It's actually managed by a federal contractor known as UNOS. And all of the policies that we have in existence today for organ distribution took years to get to the point that they are now operational, and much discussion and much input, and lots of disagreement. People disagree about how organs should be shared or who should be first. And so we have tackled those very, very difficult decisions in this country in a pretty deliberative and democratic way by making public policy that most people can live with. Not everybody is happy, but it seems to be working for us. And so the OPTN has been in existence since 1986.
I would add that whenever there's less of a good than there is needed, there's always going to be disagreement about who should get. To answer your question directly, Bob, once somebody's put on a list, their wealth or their status should not play into who gets an organ. And in fact, transplant programs are under great scrutiny to make sure that doesn't happen. And it would be a foolish program indeed that allowed that to happen. Or in fact, chose to give an organ to somebody because of the cause of their disease. Just to piggyback onto what Suzanne said, and everything she said is quite accurate, different organs are allocated based on different rules. So as you might imagine, a heart is allocated differently than a liver, than is allocated differently than a kidney, based on medical and logistical factors. Kidneys can stay out of the body longer. Livers are allocated and hearts are allocated based on how sick somebody is, whereas kidneys are allocated based more upon how well the organ is matched to the recipient. And those are based on medical facts and many years of study. And so not every organ is allocated the same way.
If I may also add, despite the fact that we have a fair and regulated system of organ allocation, it doesn't mean that everybody has equal access to organs. There are some parts of the country where people have to travel miles and miles to get to their nearest transplant center. There are some states that don't have a single transplant center. Even in states and cities with transplant centers, there are a number of barriers and disparities that prevent people that might be marginalized, that are socioeconomically deprived, people of color, who may be referred late to a transplant center, who may end up waiting longer on a transplant list, or who may simply not have the resources to travel to their nearest or best transplant center.
Is the decision, excuse me, go ahead, please.
I was going to say, I think it's actually a step worse than that. If I could just amplify what Dr. Thomas was talking about. So some people who don't have access to healthcare insurance will never get referred for transplantation in the first place. That's a problem with U.S. healthcare, not necessarily a problem with the transplant programs, or transplantation in general. Then every transplant program has its own set of rules and regulations about who they will accept and who they won't accept for transplantation based on how much risk they want to take. So access to healthcare, access to transplant referral, transplant programs themselves have their own sets of rules and regulations. And so we don't really know at a baseline how many people actually need organ replacement therapy or have organ failure because of insurance issues, access issues, and so forth.
So if you don't have insurance, you don't get on the list?
I would say that's a fair assessment. We have a whole team of people who work very hard to try and get people insurance, whether it's Medicare or Medicaid, but transplantation is very expensive, and you need to have some kind of coverage, not only to get transplanted, but to afford your post-transplant medications over the long term. Unfortunately, without a national healthcare system like exists in many countries around the world, what you said is true. Without coverage, transplantation doesn't happen in this country.
Is the decision made locally, regionally, nationally as to distribution of an organ, where it goes?
The answer to that question is yes. All organs are distributed in what are called concentric circles, but differently. So hearts, lungs, livers, all differently. But priority is given. It used to be locally first, then regionally, then nationally. Over the last 2-3 years, organ allocation has changed, and the circles of sharing have become wider. And so the first level of sharing, or what we used to consider local, which used to be for us Iowa, has now broadened to a much wider circle. I think that has penalized the people of Iowa to some degree. And whereas people in Iowa used to have better access to organs, they have less good access to organs. Now, this is better for some sicker people, you might argue, but we have a very highly functioning, well-organized organ procurement organization that procured a lot of organs. And while it may not be it may not necessarily matter to the OPO where the organs go. It matters to us and our patients. And at the end of the day, it doesn't necessarily benefit Iowans per se. And whereas we used to keep 80% of the organs procured in our state, we now export 80% of those organs. Now, you might not think that's a big deal, but from a cost perspective, it costs a lot more money to get organs in than keep them locally. It takes a lot longer to do so. It takes a lot more time to organize those phone calls from the OPO point of view, and there's good data to support all the things I'm telling you. So it makes it much more difficult to do these things.
What is, Suzanne, if you could speak to how do we increase the number of donors?
Well, that's our job. That's the job of the OPO, the Organ Procurement Organization. And there's two pathways. There's educating the public, which we do all the time. And we do that through promoting the donor registry. And we're very fortunate here in Iowa to have wonderful Department of Motor Vehicles offices. And in the smaller towns and counties, it's handled at the county treasurer's office. And those folks do a great job of asking people if they want to be donors at the time when they get their driver's license. So the public awareness is very important. And as Iowa gets more and more diverse, and we welcome people from all over the world here because we accept refugees, it is our job to try to get into those communities and educate them as best we can in their language and in their culture, because they too could need a transplant, or they could be on dialysis. So that's the public route that we focus on. And then there's the professional. And we work daily, nightly, to make sure that we get those phone calls, that we get notified when someone is near death or when someone dies at the scene of an accident, because we also facilitate tissue donation, and you don't necessarily have to die in a hospital to be a tissue donor. And tissues are corneas, bone, and skin. And so we work with law enforcement, we work with medical examiners, emergency medical services, and get referrals of people who die outside the hospital. From within the hospital, we work in intensive care units and emergency rooms to make sure that those patients who are what I will call neurologically devastated, in some way or another, their brain has been injured and they cannot breathe for themselves and they are on a ventilator. Those are the types of patients that are likely to be eligible for organ donation. And so then it's our job to work in those critical care environments to make sure that people, the healthcare professionals working at the bedside, are aware that the potential exists and that they call us timely. And then we work collaboratively with the referring professionals and with the hospital social workers and chaplains to figure out when is the best time to work with the family. Typically, we'll check the donor registry too to see if the person who is now in this situation of being traumatically injured is already registered. If that person is already registered, then it's our job to inform the family that their loved one expressed a wish, a decision to be a donor should something happen to him or her. If that intention is not registered, then it's our job to talk with the family and determine their wishes, because it's up to the next of kin in that case. If you haven't made your decision prior to, then it becomes your next of kin's decision.
So, Suzanne, if a viewer wants to contact Iowa Donor Network, how does one do that?
Well, probably the easiest way is to go to www.iowadonorregistry.org, and you can get all the information you want there. We also have an 800 number, 800-831-4131. But again, I think I would encourage going to the website because all of the questions are answered there. We have a frequently answered questions, frequently asked questions that typically people, because it can't be explained in 15 seconds, really. It's fairly in-depth. A lot of people do have questions. They have questions about their own medical history and whether or not they could be a donor. And so we deal with all of that on our website.
And so a donor can be a living donor or deceased. And how is the process, how does it work for a living donor?
If I can perhaps speak to that. So Suzanne spoke about her and her organization's efforts to increase deceased donation. In parallel, transplant centers and national advocacy organizations are working to promote living donation. And for the most part, living organ donation works only for kidneys and for livers. We educate people on the wait list about their expected wait time without a living donor. We have educational events for our referring providers, national organizations like the National Kidney Foundation, prepare educational materials that allow recipients and waitlist candidates to, if you will, spread the word about their need for an organ transplant and about how living donation works. And living donation now, at least in the area of kidney transplantation, now accounts for about 1 in 3 of all kidney transplants performed in the US a year. And we have roughly between 7,000 and 9,000 living kidney donors in the US a year, and about 250 to 300 living liver donors a year.
So to be a living donor, does one have to be a blood relative of the recipient?
Not at all. So about 40% of living kidney donors in the US are biologically related to their recipient, a sibling, a child, or a parent typically, but it could be an uncle, an aunt, a grandparent. There's also spousal donation, but with the advances in immunosuppressive therapy today, pretty much anybody can donate to anybody. And so we see close friends, acquaintances, people from their community, from their perhaps church or temple group, or even total strangers who don't know any intended candidate who step forward and approach a transplant center and say that they would like to be a living kidney donor. And Bob, you may not know this, but one of us today, Suzanne Conrad, is a living kidney donor, and she is an unrelated living kidney donor, and perhaps she can speak to her own experience and her perspective.
Sure. Yeah, so I'm a blood group O, which in the medical profession, so I can help anybody. I'm the universal donor, and I had a dear friend who had already had a liver transplant, and after 17 years needed a kidney transplant. The immunosuppressive drugs back then were harsher than they are today, and he had suffered kidney failure, and he was a blood group B, living here in Iowa. Blood group B is a very rare blood type. And so I happen to know that because this is what I do for a living. And I came forward because I I really wanted to help him, and I did not think that he would be able to wait a year or two for a good deceased blood type B donor to come along. So if you are in a rare blood type, you really do need the help of your friends, neighbors, family, if you want to get transplanted in a timely manner.
Thank you. Doctors, could you just give us an idea of the time, the wait time, if one is, it depends on the organ, I assume, but give us some idea of how long people have to wait.
Well, it's very variable, Bob. I mean, if you are just going on dialysis and need a kidney transplant, it can be anywhere from 4 to 5 years here in Iowa. If you're living in New York City or San Francisco or LA, it could be 8 to 10 years. Those are very variable, as Suzanne pointed out, depending on your blood type. If you need a liver transplant, it really depends how sick you are. If you're critically ill, you're more likely to get a liver sooner. If you're less ill, there may be a longer wait. But we've had people listed for liver transplants who are critically ill who get liver offers within a matter of days. I'm not able to speak to heart or lungs as easily as I am the abdominal organs, because that's not what I do. But hearts and lungs are also offered according to how sick you are. So I imagine it's very, very similar. Although I know it's harder and harder to get those organs as well. For heart transplants anymore, you really have to be on a heart assist device to get offers.
In our limited time, I'd like to ask the doctors to share their thoughts about the future. What does it hold in the medical transplantation world?
Maybe I could start. So we've had recently the high-profile case of a pig transplant, a bioengineered pig transplant, a heart transplant given to a person who was unlikely to get a heart from the deceased donor list. That was a major advance. That heart lasted for 2 months. Advances like that will mean that in the future, we may be able to produce many more organs in a pig that is bioengineered to reduce the risk of immediate graft rejection. And with further advances, I suspect that may be one source of organs. Two other major advances that I think are coming together that provide hope is the ability to take one's own cells, put them in a culture dish, convert them into stem cells, and then grow any cell of your choice. And then with the help of technologies such as 3D printing, you can actually create a complex structure like the external ear, the organ we use for hearing, or even more complex structures like a heart or a kidney, and then place that back into the person who actually needs an organ for their organ failure. Confluences of these technologies, I think, will allow us to either grow organs that will not require immunosuppression, or to create organs in pigs or similar animals for human use.
Well, I'm sorry we're out of time. I wish we had a couple of more hours. Your thoughts, insights, your professional experiences have been most useful and helpful. Thank you very much for participating today.
Thank you for having us.
Thank you for
Yes,
having
thanks,
us.
Bob. Thank you for having us.